Our first presenter today is Dr. Minesh Mehta, the Deputy Director and Chief of Radiation Oncology for Baptist Health Miami Cancer Institute. Dr. Mehta is a world-renowned expert in radiation oncology, proton therapy, and cancer research. Before joining Baptist Health, he served as Medical Director of the University of Maryland's Proton Treatment Center, the first dedicated pencil beam proton treatment center in the Mid-Atlantic, which he launched. He has designed and led several national and international clinical studies, received NIH and NCI grants, and has been awarded many honors. He also has over 1,000 publications, including medical journal manuscripts, book chapters, and professional abstracts. He also serves on the editorial board of several peer-reviewed journals. I now hand over to Dr. Mehta to present on Advanced Cancer Care Access, Why It Matters, Radiotherapy as a Case Study. Let's welcome Dr. Mehta.
Let me begin by saying a very, very appreciative thank you to the Ministry of Health and Wellness, to all of the healthcare entities on the Cayman Islands, and to all of you for being here today and making this such a warm reception and a warm welcome. My name is Minesh Mehta. As you heard, I am from the Miami Cancer Institute in Miami, Florida. And in a way, it's a bit strange that I'm standing here in front of you today in terms of the entirety of the topic that's being discussed, which is the healthcare ecosystem. Because what I represent is the extreme other end of the ecosystem. If we think about when we were having breakfast out there, you could actually get vaccinated while you were out there. This is where healthcare actually begins. Primary prevention, taking care of people at the grassroots level. Because if we take care of health, maybe we'll have to take care of illness less and less. But I'm going to come to you from the perspective that we need to take care of the entirety of the healthcare spectrum, not just the prevention end, which is so critically important, but also people do get sick. That's a reality. And when they get sick, they need care, and sometimes they need sophisticated high-end care. And that too is a requirement for every citizen. And I'm going to illustrate this by using cancer as an example, and specifically radiation therapy, because this happens to be one of those high-end medical arenas that requires a lot of technology, a lot of sophistication, and a huge amount of investment. And that simply can't be done in every community across the entirety of the globe, and therefore has to be concentrated in specific regions. So with that, as I mentioned, I'm going to use advanced cancer care and access to it and why I think it matters in any healthcare ecosystem. Yesterday, Shomari Scott introduced the cake as a metaphor for the ecosystem culture and structure. And I thought a lot about it yesterday. And it did make a lot of sense. A cake is sweet, everybody likes it, it rises. In other words, it takes care of everybody. And it's essentially all things to all people. But the more I thought about it, the more I realized that I don't know a single ecosystem that's flat on top. All ecosystems are inherently pyramidal. Otherwise, ecosystems collapse. You take out any layer of the ecosystem, the entirety of it collapses. And the best cakes are also pyramidal in shape. So when you start off with a cake and when you keep on building on it, you do eventually need to get to a pyramidal cake. You do need that layer on top. But what do you do in the meantime? In the meantime, you start with a structure like this: population health, primary, secondary, tertiary care, and then quaternary care. It's the quaternary care, the top of the pyramid, which is complexity exemplified. And that is what I'm going to talk to you about today. So, as an example of that, I'm going to give you first a brief description of the radiation oncology practice that I come from, and then what I'm going to do is use patients, case studies, to show you why this is necessary. This is not population health care. This is the care of specific patients that have huge challenges, and that's a reality every day in every community across the globe. And I don't know why the slides are on a timer, so I'm going to have to keep on going back. So let me start by introducing the facility. This is a world-leading radiation oncology facility with 13 radiation oncologists and 24 medical physicists. So that's going to be strange for most of you. Medical physicists practicing hand in glove with practicing physicians. But that's what radiation oncology requires. This entity has the most comprehensive radiotherapy technology platform anywhere on the globe, with a deep clinical research and clinical trial portfolio, national and international leadership, and a very impressive level of academic productivity. And the goal is to conduct research to change outcomes in patients. And today I'm going to share that with you with patient stories. You'll get to meet a few of my patients virtually, and you'll understand why this is necessary. So first of all, it takes a team, it takes a village. Cancer is not one disease. Cancer is over 250 different diseases. And if any one physician that you see in any practice tells you, I am a cancer expert, they're only being half true. Because there are so many other types of cancers that they may not be familiar with, that they may not be experts in. So it does truly take an entire village, an entire team. And this is the radiation oncologists, the physicists, the researchers, the research fellows who drive innovation and who make this happen. And as you can see, it's not one person, it's not two people, it's a massive team to make this possible. When you have a team like this, the team can investigate issues and problems in detail. And when you do that, you can learn. Medicine is a process of constant learning, constant education, innovation, research. And that's what brings cutting-edge therapies to patients who need it. This is our publication track record at the Miami Cancer Institute. Since we opened in 2017, we have now crossed 1,000 publications just within radiation oncology alone. And that clearly demonstrates the substantial academic power and prowess of focusing on our patients, learning from our patients, and sharing that knowledge and that data with the rest of the world. To do that, one mechanism that we employ, a mechanism that a lot of people use the word research for, and actually I don't like that word. The reason I don't like that word is because when it comes to cancer, innovation, new therapies, the introduction of new approaches is integral to the care of patients. Research is part and parcel of everyday care for cancer patients. So I don't want to isolate research into a separate box, into a separate pyramid, and call it different. It is part and parcel of everyday care for cancer patients. And so if you are at a good cancer facility, you should have access to the latest cutting-edge tools, even if they're in the context of a clinical trial. And in that context, at the Miami Cancer Institute, radiation oncology definitely leads the way. We're the first in terms of accruing to clinical trials within our entity. We're first in our alliance with Memorial Sloan Kettering Cancer Center, which is a very famous cancer hospital up in the Northeast. And nationally, we're second to third in terms of accruing to NRG Oncology, which is a national cooperative group in terms of leading clinical trials. Now, we can do this because we recognize very, very early on that radiotherapy, like cancer, is not one thing. Just like cancer is over 200 different diseases, radiotherapy is dozens of different technologies. And most radiotherapy centers will typically have one or two, maybe three platforms. And when they have one or two or three platforms, the perception is I can take care of everything. I can do everything. I can manage every patient. And that is simply not true. As you can see from this evolutionary graph, and this is only partial because this is already 6 months old, and we've moved on from this with newer technologies. On a continuous basis, we keep on launching a whole host of technologies. I'm not going to go through each one of these, but this collection of radiotherapy platforms that you see is the most comprehensive platform in a single roof anywhere in the world. Why do we need this? Why do we need all these machines? Do machines make a difference to patients? Yes, they actually do. Because if you have just one tool, the hammer, will say that both the patient and the doctor are nuts. Because as you can see from this cartoon, when the physician has a hammer, everything looks like a nail. And so he hits Tom, the poor patient, on the head because the only thing he has is a hammer. And the patient is very nice. He says, Pat, that's okay. What doesn't kill me will only make me stronger. And the hammer is wondering, says, these guys are both nuts. You can't use a hammer as a screwdriver. A hammer is for a nail, not for a screw. And therefore, you need the right tool for the right job. Any person who comes to repair anything in your house will tell you that if they don't have the right tool, they're not going to do the right job. And it's the same in medicine, it's the same in radiation oncology, it's the same in cancer care. If you don't have the right tool, you won't do the right job perfectly. The right tool is crucial. But it's not just about the tools. It's about deploying the tools for each and every one of our patients. And deploying these tools can take a lot of innovation. It can take a lot of thinking by the seat of your pants, especially when you see very complex cases. We do have very standardized approaches for managing cancer. Everything is done in the context of clinical pathways. Everything is done in a very standardized manner. There's only one problem. Patients don't read standardized pathways. Diseases don't read textbooks. And as a consequence, the exception is the norm. We see huge numbers of patients that don't fit into these well-defined clinical paradigms of thou shalt do this. There are so many exceptions to all of this. And it's the exceptions that we need to be able to take care of, because if you can't take care of an exception, you can't take care of the routine with the same level of efficiency and effectiveness, care, and compassion. And so I'm going to use these patients who are all exceptions. These are not routine patients. And I'll tell you their stories, because our best ideas in terms of what to do for our patients globally and generally come from these complex, difficult patients, because these require our research teams to come together and innovate. So let me start you off with this 10-year-old girl. If you look at the bottom panel, the picture to my left, as I see it on the screen, where you can see her face is contorted. Her face is contorted because she has a paralysis of the 7th cranial nerve, the facial nerve. And she has a paralysis of this, consequential to the MRI scan that you see on top of her picture. That is a tumor in her brainstem. This diffuse intrinsic pontine glioma is notorious for causing all kinds of cranial nerve paralysis and pulses. This, by the way, was the picture at completion of her radiotherapy. So this is an inoperable tumor. It can't be resected. It can't be removed. And there's not a single chemotherapy known to mankind that has an effect on this tumor. Radiotherapy is the only treatment that is used, and it's a relatively straightforward, run-of-the-mill, routine, bread-and-butter type of radiotherapy that is utilized. So she completes that. She's attempting to smile, and that's what she can do at best. Mom comes to us and says, this is not good enough. We all know she's got a tumor left. We all know that this is going to grow in a matter of weeks. And when that happens, the 10-year-old will be dead. We need you to think about this. Go home and think about this. I'm not going home until you find a solution. So we thought long and hard. And at that time, there was one single case reported of an adult with a very different tumor on a clinical trial receiving an experimental drug called ONC201 or ONC201. This had never been combined with radiation. This had never been used in the pediatric setting. This had never been given to a child. But given how determined the patient and the family were, we were able to approach that particular pharmaceutical company, write a one-patient clinical trial, and enroll this patient on a one-patient clinical trial. And you can see her smiling. So where there is a will, there is a way. Where you want to innovate, you can. So the patient sustained radiographic progression, had a substantial and dramatic response. The consequence of this was not just this one patient. This is not an effort for one patient, but the one patient is the one that leads the way. And the way she led the way was by allowing our team, and it took 3 of these individuals to put their brains together. There's always a woman in the middle, okay? It took 3 of them to put their brains together to come up with this wonderful idea. And all 3 of them are very different. Matt Hall is a pediatric radiation oncologist, par excellence. I don't know one better. I can say that because I used to be a pediatric radiation oncologist, and he can kick my pants any day in terms of his skill set. Dured Dagestani is a pediatric oncologist, takes care of kids. But in the center is Yasmin Odia, who's a neurologist and an adult oncologist. So we brought expertise from various different domains to put together this idea of using this drug, ONC201. This led to a publication in Cancer Discovery in 2023, which, as you can see at the bottom, a very famous lay press journal reported as a major crack in the armor. The title was Scientists Find New Weapon Against Brain Tumors, a Major Crack in the Armor. And as you can see, 4 of the authors are from the Miami Cancer Institute. This has now led to a global phase 3 randomized trial that is launched all across the world for this very difficult, hard-to-treat tumor, which is, in fact, surprisingly more common than we ever thought it was. The tumor is characterized by a mutation, a recently, relatively newly diagnosed mutation, known as an H3K27M mutation, which occurs in the chromatin folding apparatus of the DNA, which we never thought would be where mutations would lead to cancer. We always thought they're always in the DNA that's involved in replication and proliferation. But this is actually in a folding protein. And this is an unusual mutation leading to cancers, and now we have a drug that's being tested globally. So thanks to this one patient who came in without a smile and insisted that we make her smile, we hope that we can make the world smile with the results of that phase 3 randomized trial. That's why we take on difficult patients. It's not because difficult patients are the only ones where we need to solve problems, but they give us clues as to how to globalize solutions for the rest. So let me now move that theme to this next patient. This next patient, the lady in red, everybody knows the meaning of that comment, had unresectable pancreatic cancer. And for those of you who know pancreatic cancer, it's the 5th leading cause of cancer death in the world. It is the disease that gives cancer a bad name. Cancer is bad. Pancreatic cancer gives cancer a bad name. This is a lethal disease. People die when they get this disease. You get this diagnosis, you pack your bags. Unfortunately, this is exactly what happened to this lady. She lived elsewhere, not in South Florida, and had, unfortunately, inoperable pancreatic cancer. She went online, did her research together with her husband and together with her supportive family, and realized that at the Miami Cancer Institute, we were doing something different and something unique for inoperable pancreatic cancer. This was in the early days when we had launched this program that I'll tell you about in a minute. But she was brave enough to reach out and say, I know this is early. I know you've treated a few patients, but I want in. I want to come in and be taken care of. So she came in. At the bottom, she tells us that she went through a treatment, which was just a 2-week course of treatment. There was no pain, there was no discomfort. In fact, she felt nothing when the radiation was delivered and was able to go home and survive. These are all post-treatment pictures. You tell me, when you look at this lady in red, if you saw her on the street, would you say this is a person with pancreatic cancer? Most of us would not. She looks perfectly normal and healthy. And in fact, the headline was she defeated inoperable pancreatic cancer using the most advanced radiation therapy that she received at Baptist Health Miami Cancer Institute. So what is it that we did? What is it that's different that we did here? Well, we had just deployed a new technology called the MR-Linac, which is the marriage of an MRI scanner with a traditional linear accelerator that delivers radiation therapy. This produces unprecedented accuracy and the ability to guide the radiation to the tumor and avoid normal surrounding structures, like the duodenum, for example, which is kind of important. You need it, okay? And the reason this is crucial is because we have never managed to give sufficient radiation dose to pancreatic cancer, because if we did that, we'd blow a hole in the duodenum. And a hole in the duodenum is the same as death. And therefore, we never give high enough doses to pancreatic cancer. But with the MR-Linac, we can control the delivery of the radiation by allowing the machine, using artificial intelligence, which can see the images and avoid the duodenum and target only the pancreatic cancer. So, of course, we had to put a team together. And as I keep on telling you, always put a woman in the middle of the team. And so Kate Midtower was not an MD, that's an error. She's a PhD, she's one of the physicists one of those 25 physicists that you saw, with Adil Kaiser and Michael Chong, who's the head of our MR-Linac pancreas program, devised a clinical trial for using very aggressive radiation dosing approaches, all delivered in 5 treatments, over and done with in 2 weeks. These are the latest results. In the rest of the world, anywhere you go, if you have inoperable pancreatic cancer, your 2-year rate of survival with the most advanced chemotherapy and radiation is 20%. If you come to a center like ours with MR-guided stereotactic ablative body radiotherapy, and there are now multiple other centers that have replicated our results, and in fact a multi-center report of the collective of all of these centers was just published last week, your odds go up to 50% survival at 2 years. This is still not fully curative in all patients. Half of our patients are still passing away in 2 years, but it's not 80% that are passing away in 2 years. For patients like the lady that I showed you, this is enough to warrant sophisticated advanced care. And in fact, this, as of yesterday, is now recognized by the American Society for Therapeutic Oncology as a new standard in the management of pancreatic cancer. And the report just came out yesterday, will be published as a manuscript in the next month or so, and will become a new standard in managing pancreatic cancer. We had a 36-year-old lawyer who came to see me and my colleague, Rupesh Kotecha, with the 5th recurrence of a malignant glioma. I told you about pancreatic cancer giving cancer a bad name. Malignant gliomas give cancer of the pancreas a bad name. Okay, they are even worse. This highly aggressive recurrent tumor has no cure. This is lethal at diagnosis. People die within weeks to months of this diagnosis. And the reason for that is, God didn't give us 2 brains. He gave us 2 kidneys. You could lose one, you could go on the other one. You don't have 2 brains. You can't just get rid of one and live on the other one. You lose your brain, you're done. You're done and dusted. And the problem is the brain is in a closed box called a skull. And the moment you try to stuff anything more into a closed box, you get swelling. And when you get swelling, everything pours out of the back of your neck through the spinal cord, and you die of increased intracranial pressure. So there's nothing you can pack into the brain, not even a tumor. And tumors love to do that. They love to pack the brain with tumors. As you can see from that huge, big white glob on the left-hand side, on my left-hand side, it's probably the right-hand side. No, it's on your left-hand side as well. This is a massive recurrence, and it's her 5th recurrence. She has had every treatment known to mankind. Shows up in our clinic and says, I understand you guys think outside the box. Well, here I am. Think outside the box. My expertise is brain tumors. My colleague who saw this patient brought the scan to me, and I said, we need to consider hospice care for this patient. We don't have any alternative but hospice care. There is no treatment that can be done for this. And he responded by saying, well, that's exactly what I told her. And she said, I'm younger than you. I have 2 young kids at home. I'm not leaving until you come up with a solution. And so we decided to scratch our heads. And as you can see, we did something that basically got rid of this entire tumor. You can see the pre and the post MRI scans, the whole tumor is gone. So how did this happen? What did we do? This, by the way, is published. It was published last year in Neuro-Oncology Advances. What we did is we put a team together. Unfortunately, this time to put myself in the center because I guess I'm one of the girls, So, I'll count, But we used a physicist again. That MD is an error there. It should be a PhD. That's Alonzo, who's our physicist. And Rupesh Kotecha, the Doogie Howser, that's the guy who saw the patient and brought the patient to us in our neuro-oncology clinic. And we put together a technique called proton pulsed reduced dose rate re-radiation. This technique has a very interesting origin. The technique was invented in a laboratory in England, known as the Gray Lab, in the 1920s to treat mice, to treat the skin of mice, because in those days, the technology for delivering radiotherapy was kilovoltage radiation, the kind of radiation you get when you get your mammogram or when you get a chest x-ray, things like that. The problem with that is that's very superficial radiation. It does not penetrate deep in terms of sufficient dose. And as a consequence, if you jack up the dose, you will burn the skin with that. And so when they were treating these mice for experimental purposes, they would create a tumor on the mouse, treat the mouse, the skin would burn off. So they came up with this technique of pulsing the radiation dose by changing the dose rate, because the dose rate has biological implications. And they were able to spare the skin. And then the technique died, because it was a technique in the lab, it was for mice, and that was really about it. And a handful of people across the globe have used it with conventional radiation, conventional photon radiation. So we used Alonzo's physics expertise, rejigged the entire proton machine to create this approach of proton pulsed reduced dose rate re-radiation, and treated this patient. As a consequence of the result that you saw, we of course now have a clinical trial for patients with multiply recurrent malignant gliomas that are now being enrolled, and this trial is up and running, enrolling patients like the 36-year-old that you saw. We then had this 87-year-old. The picture is deliberately blurred because I know some of you just had breakfast, so I want to make sure that it's not too nauseating. But this gentleman, unfortunately, 89, not 87, I'm sorry, 89-year-old, with a multiply recurrent squamous cell carcinoma of his scalp. This is part of the price that melanin-deprived individuals pay when they move to the state of Florida. The sun doesn't quite like those people in Florida. And as a consequence, the sun beats down and causes skin cancers, and these are multiply recurrent. This had been previously heavily treated with surgery, with resection, with systemic therapy, with radiotherapy, with everything. And the patient had a more than 6 centimeter recurrence within 3 months of the last course of radiotherapy. He was told to go home and go to hospice. Well, this tumor is not going to kill him, but this tumor is going to eat through his head. And it's going to take months to years before it does that. So you can go home and have a tumor eat through your head or come up with something else. And so we went back into the history books of radiotherapy and actually identified a radioisotope, radium-224, not radium-223, which is conventionally used for radiation therapy, which is now actually embedded in specific seeds. This is work done with a specific company, which has now led to a device called the Alpha DART. And this is actually embedded in the patient's tumor. This is how it's done surgically. So we put a team together, and this time Dr. Young is the head and neck surgeon, and I should have put Viva in the center of it. She's the physicist, not the MD again. And Noah Coleman is our head and neck cancer expert. So surgically, they put catheters through the patient's head that you can see in the middle picture, which again is blurred to make sure that you can keep your breakfast down. But you can see on the CT image how each of these catheters parallels this, and the Alpha DART seeds have been embedded. Once the procedure is done, and the patient had 87 such seeds embedded in here, you can see the guy is enjoying his ice cream. It's all done under a local anesthetic. Goes on to have a complete response, and his tumor was taken care of. This is now a global clinical protocol that's available to multiple patients with this difficult to take care of condition. Recurrent lung cancer is unfortunately another kiss of death. Recurrent lung cancer has no known therapy that works. When Doogie Howser, Rupesh Kotecha, saw this patient, 71-year-old, stage 4 non-small cell lung cancer, which was negative for all of the actionable mutations for which we have amazing drugs in the clinic today. The patient had received 3 cycles of the most effective systemic therapy and had experienced disease progression. He enrolled this patient on a very intriguing, unique protocol, which uses, of all things, electricity. Yes, electricity. This trial, known as the EF24 trial, which at that point in time was a global international phase 3 randomized trial, combined electricity with chemotherapy. The electricity is applied through a battery apparatus, and as you can see, the patient actually has a number of electrodes that are just pasted onto the skin. And these arrays deliver electrical current, which polarizes the DNA, making it more sensitive to DNA damaging agents like radiation and chemotherapy. And this was a clinical trial which we led the country for. We had the highest accrual and was presented at the ASCO 2023 meeting. ASCO is the largest cancer meeting in the world. This was a paradigm, practice-changing lung cancer trial which led to a survival improvement in patients receiving the electrical fields plus standard of care. Obviously, a significant majority of patients still die of their cancer, but it does incrementally improve survival in patients with recurrent refractory lung cancer. This is now at the FDA level, and today, this morning, the Miami Cancer Institute became the first certified facility anywhere on the planet to be able to offer this therapy to patients off trial. Taking a cue from electricity, we had also launched in parallel a trial in brain metastasis. Again, as you will see, I'm not talking to you about simple cancers. Everything that I'm sharing with you is complicated, tough, very hard to take care of. Brain metastasis at a population level has a median survival after diagnosis of under 6 months. This is, again, a lethal disease. So, recognizing the value of this electrical field therapy, which is known as TT fields, we had a parallel trial called METIS. The prior trial, by the way, EF24, was called LUNAR. This trial is called METIS, which is also an international multi-center phase 3 randomized trial evaluating the safety and tolerability of this therapy, tumor treating fields, in patients with lung cancer with brain metastasis. At ASCO 2024, a year after the LUNAR trial, we were able to present the results of the METIS trial. And on this METIS trial, the design was very simple. Patients with lung cancer with brain metastasis received the best supportive standard of care therapy with or without tumor treating field therapy. And the primary endpoint was intracranial failure. And as you can see, the best supportive care arm had a significantly higher rate of intracranial progression and failure compared to the tumor treating fields and best supportive care. And this was also statistically and clinically favorable in terms of patients with non-small cell lung cancer and is now in line at the FDA for potential approval. Not yet approved. The data are being presented, the manuscripts being written. Hopefully, by next year, I might be able to tell you that this is now an approved therapy. This is the last patient case that I'm going to share with you, and then I'll start wrapping up. This is a benign tumor. Remember, every tumor that I've shared with you so far were all terrible, horrible tumors that people die of. This is a meningioma. People don't die usually of meningiomas. It takes a very, very, very long time to die of a meningioma. But it can do nasty things to you. This is a patient with a multiply recurrent meningioma after everything you could do before. We don't take care of the simple stuff. We only take care of everything's been done and what do you do now kind of stuff. So unfortunately, this patient came into us blind in that one eye where you can see the tumor circled in green. And she had a very simple request. She loved Barnes and Nobles, and she loved to read. And she's like, I don't care how long I live. I just want to read again. Give me my vision back. And the first thing we told her was, well, that's an impossibility. That can't be done. There is no treatment known to humanity that restores vision after it's been destroyed with meningioma. Without boring you with the full story, we had incidentally, almost serendipitously, noticed that a drug in development for a completely different indication, thyroid cancer, in a patient that we were treating on a clinical trial who also happened to have an asymptomatic meningioma in the brain, demonstrated regression of the meningioma with this drug, cabozantinib. So we wrote a one-person clinical trial for this patient, treated her with cabozantinib. And as you can see, her tumor shrank and her blindness reversed. And of course, there's a woman at the middle of it, Yasmin Odia. Okay, so we now have a clinical trial with cabozantinib The drug company is now going back and reformulating cabozantinib into a newer drug, which could potentially be more effective, so that presumably we'll have a new therapy for this disease down the road. So all of these examples are driven by one mission, a mission of passion. And that mission is patient satisfaction. What can we do for that each unique individual patient that walks in with a problem? If it's a simple, straightforward, easy problem, we can apply a population-based solution. We can apply a clinical standards-based solution. We can apply a globalized, systematic solution. But what about the rest? For those patients, it's the individualization, the personalization. And at the end of the day, the reason I go to work is I get to see comments like this the first. I'm not the one that generates these, it's my team. But I take credit for them because they come to me first. And I'll read this one out to you, okay? This is a physician who had advanced recurrent metastatic prostate cancer, who had been treated at every major center in the United States, had exhausted every opportunity, and then went to Germany for an experimental treatment because it wasn't even available in the US. And when he progressed on that treatment, came back, and everybody told him, well, you're a cardiologist, you need to understand, end of life comes to everybody, time to pack your bags, okay? He showed up at our doorstep. We did something innovative and unique. I'm not going to tell you the whole story. He's still alive 6 years later. This is a quote he sent to our CEO. He said, I wish to applaud the culture you have developed with the focus on world-class technical care combined with world-class genuine hospitality, kindness, and empathy for the patient. A winning combination, unique in my experience, and quite noble. So, let me end by telling you that ecosystems are multi-layered and complex. Yes, they are cakes, but they are pyramidal cakes. And there is a top at the top of the pyramid that needs to be taken care of. I hope I've convinced you that we are part of your ecosystem in areas of need for quaternary care that's patient-centric, high quality, and innovative. It's not always a hammer that solves everything. You need the entire toolkit. So when you need more than a hammer, who are you going to call? Thank you.
Thank you very much.
Take some questions.
Dr. Mehta, we do have the opportunity for some questions. So if you do have questions, just raise your hand and we'll get a mic to you. So I'll try and keep an eye. But one question for you, Dr. Mehta, while we wait to see if there's any from the audience. How much inspiration do you and your team get from the resolve of people who are facing these life-altering, life-ending situations to continually innovate to provide these solutions?
It's almost as if I planted this question, which I didn't, okay? Just earlier I was having a conversation that my son is also a physician in training, completely unrelated to all of this. He got mugged yesterday because he's at the premier healthcare system in the United States called Johns Hopkins, which if you've ever seen the neighborhood, it's prime territory for getting mugged every minute. But he started life as an epidemiologist. And the reason he started life as an epidemiologist was because he told me, he said, Dad, I know I got into med school, but I'm going to turn down my med school application, and I'm going to go to Emory and get myself a degree in epidemiology. Because as a physician, you can only take care of one life at a time. But as an epidemiologist, as a public healthcare policy driver, I can take care of entire populations. And that's so much more enriching and fulfilling. And I said, well, whatever. And so he went and became an epidemiologist, then went to med school and is now a physician. And I think the reason this happens is epidemiology and public health has a global impact. It has a very large-scale impact. But you don't see that every day in your patient's eyes. You don't sit in front of your patients. You don't see a blind patient reading a book. But we get to see that in our clinical practice. And nothing more than that can drive a physician to work every day, if necessary, 24 hours a day. So that's the inspiration, that's the reason why patients drive us to work.
Thank you very much. Do we have any questions? You could just indicate by raising your hand. I see we have a question to the far left. 1 second, we'll just get you a microphone so that we can hear your question clearly. We may have room for a second question. So if you do have a second question, just raise your hand. I will identify you. Yeah, let's have this first question.
Thanks for the talk. Just circling back to your slides, with regards to the LUNAR trial and all the trials that you've presented, you did mention that patients had improved longevity in their lives, so about maybe 3 to 6 years. Does that also translate to quality of life that they had?
That's a superb and a phenomenal question. And all of these trials had quality of life components built into them. And all of these analyses are ongoing and in general are supportive in the right direction. But that's a very statistical answer. I'm going to give you the answer perhaps a little differently. Because the real challenge for us in oncology is that these advances buy us very modest incremental gains in survival. And so at a population level, the question that we have to ask, and I'll give you a very simple example. I'm sure breast cancer is a disease that's very, very familiar to most of you. And there is a type of breast cancer called HER2-positive breast cancer, for which the first therapy that became available was a drug called Herceptin. Today, Herceptin is standard of care across the globe for women with HER2-positive breast cancer. But I remember when that first trial was presented at ASCO, and the drug was applied for approval in the UK, it was denied. It was denied because there was an assessment by a panel that the magnitude of benefit was not economically defensible. Today, it's globally available to everybody. So this is the real challenge, right? When we do an economic analysis of some of these therapies, they can be expensive, the incremental gain is modest, and yes, quality of life parameters need to be included. The personal aspect to that story that I'm going to tell you is my dad. He just turned 93 2 weeks ago. He has dealt with multiple clinical problems, and his most recent clinical problem, after effectively being a cardiac cripple, was the inability to pee because of a large prostate gland. He was offered the option of having a chronic indwelling catheter the rest of his life, however long it could be, or going in for a laser procedure which would enucleate the prostate. He had the enucleation. We tried to talk him out of it, and he said, it's quality of life. I'm not wearing a catheter. Immediately after the enucleation, he had, unfortunately, a massive infection from release of bacteria from his urinary tract into his blood. He experienced septicemia, required an acute care emergency stay in the ICU for 8 days, and we all thought he was dead. He's home, peeing by himself, making his omelets every morning, and doing well. And if he does that for 6 more months, I'm happy. I'm okay with that. If he gets 6 weeks out of that, being happy making his own omelet, I'm happy with that. That, to me, is quality of care, when the patient is happy with their own life.
I think we can move forward now and thank Dr. Mehta for that presentation. Thank you very much.
Appreciate it. Thank you.